All right, let's jump right into this high-yield explainer tailor-made for medical students who need a rapid, absolutely bulletproof review of COVID-19. Whether you're prepping for boards or you're out rounding on the wards, you know the sheer volume of data surrounding this virus can feel, well, totally overwhelming. So today, we're cutting through all that noise. We're focusing strictly on exactly what you need to know to ace those exams and safely manage your patients.
We're following a strict clinical pathway arc today. We'll start with virology and pathogenesis, move into clinical presentation and diagnosis, map out outpatient and inpatient treatment ladders, and finally, finish up with the high-yield exam traps.
Section 1. Virology and pathogenesis. Let's kick things off with the bug basics. We need to introduce our villain, the SARS CoV-2 beta coronavirus, and see how it actually breaches our cellular defenses.
Take a look at this number, roughly 30,000. That represents the nucleotides in its positive sense single-stranded RNA. And what's really wild is that this makes it the largest known RNA viral genome. I mean, for an RNA virus, that is just massive. Now, it's an enveloped virus, likely originating from a bat reservoir, and it comes packed with 4 main structural proteins. You've got the spike, the envelope, the membrane, and the nucleocapsid. But as you probably guessed, it's that spike protein we really need to focus on.
Right, so the absolute crucial point here is understanding this lock-and-key mechanism on a molecular level. The virus's spike protein uses its receptor binding domain to target the ACE2 receptor on our host cells. But here's the kicker. Just attaching isn't enough. It strictly requires the host protease, TMPRSS2, to actually prime that spike protein. Without this priming step, membrane fusion and viral entry just don't happen. Examiners absolutely love testing this two-step entry mechanism, so you've got to make sure you have both ACE2 and TMPRSS2 completely locked in your memory.
Moving right along to Section 2, Clinical and Diagnosis. So, the virus has entered the cells and started replicating. Let's map out what this looks like clinically and how we reliably confirm the diagnosis.
In a clinical vignette, you're definitely going to see the standard infectious symptoms, right? A 4 to 5 day incubation period followed by fever, a cough, maybe some dyspnea and myalgia. But while you'll see fever and cough in almost every respiratory illness under the sun, anosmia, that's loss of smell, and dysgeusia, loss or change of taste, are the highly distinctive classic hallmark symptoms you've got to watch out for. If a test question mentions a sudden loss of smell or a weird change in taste, your brain should immediately scream COVID-19.
And hey, we can't talk about clinical presentations without highlighting an absolutely critical pediatric syndrome, MIS-C. You've got to remember multisystem inflammatory syndrome in children as a severe complication. It presents with persistent fever, multi-organ involvement, and a massive spike in inflammatory markers. And keep in mind the specific demographic vulnerabilities that board exams love to highlight. It carries the highest risk in Black and Latino children, specifically between the ages of 3 and 12.
Now, this brings up the classic diagnostic trade-off we face in the clinic. When confirming the diagnosis, you essentially have 2 main pathways. Antigen tests, they're rapid, they're great for at-home use, but they are significantly less sensitive. This is especially true if your patient is entirely asymptomatic, which, remember, happens in about 30% of cases. On the flip side, the RT-PCR test is your heavy hitter. It's molecular, requires a reference lab, takes a bit more time, but it remains your absolute gold standard and the most sensitive test for definitively ruling out an infection.
All right, let's shift gears to Section 3, Outpatient Treatment for Mild Disease. This leads us straight into the most highly tested material on your boards, the specific pharmacological treatment algorithms. But before we map out the options, let's test your active recall. Imagine a patient walks into your clinic. They've got multiple risk factors for severe disease. Maybe they're over 65, have a BMI over 25, or they have diabetes. But right now, they only have mild symptoms. What is your absolute first-line pharmacological defense to keep them out of the hospital?
If you said Paxlovid, you hit the nail on the head. Your go-to first-line treatment is nirmatrelvir-ritonavir. Here's how it works. Nirmatrelvir is a protease inhibitor that stops the virus from replicating, but it relies heavily on ritonavir. Ritonavir acts as a pharmacokinetic booster by inhibiting CYP3A, keeping those drug levels nice and high in the body. Now, if you can't use Paxlovid for some reason, your backups are either 3 days of IV remdesivir, which inhibits viral RNA polymerase, or the oral ribonucleoside analog, molnupiravir. But remember, those are strictly backup options.
But there's a major catch with Paxlovid, and it revolves around a number you absolutely cannot forget: less than 5. Nirmatrelvir-ritonavir must be started within 5 days of symptom onset to actually be effective.
If your patient rolls in on day 7, that oral option is totally off the table.
And speaking of things being off the table, let's talk about one of those backup drugs. This is a massive exam red flag. Molnupiravir works by intentionally inducing RNA mutations in the virus. And because of that mechanism, it carries a severe black box warning. You must never, ever prescribe molnupiravir if there is any potential for pregnancy. It's highly mutagenic and strictly contraindicated. Do not miss that on test day.
Okay, moving on to Section 4, Inpatient Treatment. Let's escalate our algorithm and look at severe disease, where the virus has really taken a strong hold.
So think logically about the clinical pathway here. Your patient is now admitted. The virus has caused enough pulmonary damage, often showing up as bilateral ground glass opacities on a CT scan, that their O2 saturations have dropped. They need supplemental oxygen. Because the disease state has evolved, we need a totally different pharmacological arsenal. What are your immediate moves?
The very moment oxygen is required, your standard baseline treatment instantly becomes a combo of IV remdesivir and 10 days of low-dose dexamethasone. The remdesivir fights the actual virus, while the dexamethasone reduces the cytokine-mediated lung damage. But what if they continue to crash? If they suddenly need high-flow oxygen or a mechanical ventilator, or if their inflammatory markers just skyrocket, you've got to escalate. You step up by adding a powerful secondary immunomodulator, and you'll specifically choose either baricitinib or tocilizumab.
Now let me really emphasize this trap, because honestly, it's one of the most common mistakes made by test takers and junior clinicians alike. Dexamethasone provides a benefit only when oxygen is required. Remember, it's an immunosuppressant. This means it will actually harm your patient if you give it too early during that mild outpatient phase. Why? Because you'd be suppressing the immune response exactly when the body needs it the most to clear the virus.
Let's look a little closer at those escalation options. When you're trying to combat a massive cytokine storm, you're going to choose between two really powerful immunomodulators. Tocilizumab is a humanized monoclonal antibody, and it directly blocks the IL-6 receptor, IL-6 being a massive driver of the cytokine storm. Baricitinib, on the other hand, is a JAK1 and JAK2 inhibitor that broadly reduces inflammatory signaling. Both of these are your heavy hitters for worsening inpatient disease.
Oh, and there's one more universal rule for the inpatient setting. Because this virus is highly prothrombotic, it causes massive spikes in D-dimer and can lead to deadly DVTs, pulmonary embolisms, and arterial thrombosis. Pharmacologic VTE prophylaxis is an absolute must across the board. Practically every single hospitalized patient should receive therapeutic dose anticoagulation. We're typically talking heparin or low molecular weight heparin here, unless, of course, they have an absolute contraindication.
All right, to wrap up this explainer, let's dive into Section 5, High-Yield Exam Traps. Let's rapidly review the red flags and pharmacological traps that examiners love to use to catch you off guard. Knowing these tricky exceptions and interactions is exactly what separates the good scores from the truly great ones.
You've got to memorize these red flags. First up, remember that the ritonavir and Paxlovid heavily interacts with CYP3A drugs. You absolutely must check your patient's medication list for things like statins, colchicine, or immunosuppressants like tacrolimus before you even think about prescribing it. Second, renal function completely dictates your Paxlovid dosing. You have to dose reduce for an eGFR between 30 and 60. And finally, here's a historical but still highly testable vaccine fact. The Janssen or J&J viral vector vaccine was completely withdrawn from the market. Why? Because of TTS, thrombosis with thrombocytopenia syndrome. It's a rare but super severe clotting complication that's pretty similar to HIT.
So, I'm going to leave you with one final, essential clinical scenario to ponder. If your COVID patient's eGFR drops below 30, which first-line drug must you instantly avoid, and what is your backup? Well, if you remembered our outpatient ladder, you know Paxlovid is immediately contraindicated in severe renal failure under 30 eGFR, meaning you'll need to pivot fast to a backup like IV remdesivir. I really hope this explainer has successfully hardwired these vital pathogenesis steps and treatment algorithms right into your memory for exam day. So keep reviewing, stay focused, and go crush those questions.